So this is nursing care of the child with the alteration and elimination, specifically genitourinary disorders. So what's the difference between kids and adults? Well, the proportion of the abdomen that the kidneys fill up are larger in the child, which means it's easier to injure the kidney if they get hit in the abdomen, or particularly if they get hit in that lower back over the kidneys. The urethra is short, so irritation on the skin of the peri area doesn't have far to travel. Germs don't have far to travel to get into the bladder and cause a UTI. The glomerular filtration rate is slower in infants, and this means they can't concentrate their urine. So if they don't take in a lot, they will just pee less, but they won't concentrate the urine the way an older child or an adult will. And then the reproductive organs obviously are immature at birth and don't mature until adolescence. So some of the common labs we do: CBC, we're looking for infection, right? BUN, I always like to connect BUN and creatinine together. That's telling us about some of the waste products and are they being cleared. So can the kidneys clear them out? Electrolytes, remember, where sodium goes, water goes, and infants and young children don't concentrate urine well, which means they're losing water and electrolytes together. Protein, albumin is the majority of the protein in the blood, so we can look at total protein or albumin, and remember that's a big molecule that takes up a lot of space, and when your body's trying to make, do simple diffusion, get equal amounts, that big product pulls water in because of the volume it takes up. It's going to pull water in, so it's got that oncotic pull. So without it, we get problems of the plasma, the water and electrolytes of the blood shifting out. So urinalysis can be done clean catch, suprapubic, or an in and out catheter. And remember, a culture and sensitivity often is needed. So the urinalysis is just looking at the urine, and then the culture is putting it on the little petri dish to see if germs grow, and the sensitivity is putting the antibiotic discs on that petri dish to see if they stop it from growing around that disc. Creatinine clearance, looking at how well the kidneys clear the creatinine. Sometimes this is a 24-hour creatinine clearance or 24-hour urine protein. So we want to know that we're starting with an empty bladder. So the child voids, we toss that and we time it. That is the timing we're starting. So 24 hours later, at that time, we have the child void and keep that urine. So we make sure we start with an empty bladder, and then we have the child empty the bladder but use that one at the end. We can do scopes to look at inside the bladder, look at how things are going. Voiding cystogram, we're looking at we put contrast into the bladder and use the fluoroscope, right, because that contrast shows up really well, so we can see where urine is moving or isn't moving. Renal ultrasound, looking at the organs. Intravenous pyelogram, so they're putting IV contrast rather than with the voiding cystogram, they're putting it in the bladder. This time they're putting it IV, and putting that contrast in makes things show up differently on x-ray. So we can get a x-ray that shows the kidneys, and sometimes if they're really concerned, they have to do a biopsy. They have to take a little bit of the tissue and look at it, and that's usually just kind of a needle biopsy. It hurts, but it's not like a open surgery. So some significant data that you need to assess when you're getting the medical history for a GU disorder. We want to know the past medical history, particularly during pregnancy. Was there any issue with amniotic fluid? polyhydramnios or oligohydramnios, a lot of that amniotic fluid is the baby swallowing and peeing, right? So that tells us something about how the kidneys were doing, the fetal kidneys were doing. If mom had diabetes, hypertension, this changes blood flow to the baby. If mom had alcohol or cocaine ingestion during pregnancy, again, that can be significant. Neonatal history. If the baby is born with a single umbilical artery, an abdominal mass, if they have some sort of a chromosomal abnormality, Down syndrome sort of thing, or some other congenital malformation. They're born with something abnormal. And just the ears and the kidneys develop at the same time in utero. They actually develop from the same tissue and are developing at the same time. So any abnormalities in the ear, that's a baby who needs to be worked up to see if the kidneys are normal or not. And if you think about it, those medications that are really hard on the kidneys, also if you get toxic with them, they can cause hearing loss because the kidneys and the hearing are closely related tissue-wise. And then family history. Is this something that's gone on in the family? Is there a history of renal disease or some other uropathy? Is there chronic UTIs of one of the parents or the other siblings? Renal calculi, right? Are they making stones? Or history, if the parents had history of nighttime bedwetting past the age of potty training, that's enuresis. Their children are more likely to have it. So how do we get this diagnostic? So we can do a clean catch, which is great, but you can't do it on an infant, right? That's the clean catch. We want them to clean, start voiding, stop, pee in the cup, take the cup away, finish their void. Okay, you can't get a child, even early potty trained child can't do that. So what we can do on an infant is a urine bag. You clean them and then you seal it on their well. If nothing is in there, nothing grows, we can rule out that they have a UTI. But if something does grow, we can't be sure whether that was a contamination or if that, from the skin, or was that in the urine. So it can be helpful to rule out, but it can't rule in some of the problems. So in and out catheter, just like that clean catch, it's ideal to waste the first few mLs and then collect it. Suprapubic, and I've been in nursing long enough, I've kind of seen each of these, the U-bag, the INO, and the suprapubic be the method of choice for a decade, and then they go to a different one. So a physician has to do the suprapubic, but they puncture into the bladder and draw out urine, and it looks bad, but the babies don't really cry that much during it. So I don't think there's a lot of nerves there. It's not terribly painful, and you get a good sample. These are the urinary and renal disorders we're going to look at. We'll look at some structural problems, and then we'll look at some acquired problems. So structurally, bladder exstrophy, or exstrophy of the bladder, means the baby was born with the bladder outside the abdominal wall. This is going to have to be put back in surgery, but in the meantime, this is an internal organ, right? Internal organs are supposed to be moist, so keep it moist. Usually it's just a saline covered gauze or saline saturated gauze over it. Keep the baby supine. We don't want them laying on it. We want to avoid getting germs in there, so change soiled diapers as soon as possible. And depending on where the meatus is and how the baby's voiding, you may have urine coming out. You may need to kind of protect the skin from moisture and problems. Hypospadias or epispadias. This is a male where the meatus is not at the tip of the penis. So hypo, it's down below. Epi, it's on top of the shaft of the penis. So this, we're going to do surgery to correct it. They usually wait till after a year. just so that everything's a little bigger, easier for the surgeon, but they like to do it before they're 2, so they really don't remember it. And by the time they're getting potty trained, they're able to stand and void normally. The other reason to do it is to make a sexually adequate organ, because if you're, ejaculating somewhere down here or up there, fertility is going to be an issue. And just for self-esteem issues, minimize the emotional trauma. So this child, what we do want to do, if sometimes they can just take the meatus and move it, but if it comes out quite far from the tip of the penis, they're going to have to make some urethra. They like to use the foreskin. So this baby shouldn't get circumcised because they'll use that in surgery. Okay, so obstructive uropathy. So this, just as it sounds like, it's an obstruction that causes a kidney problem. And it can be pretty much at any point down through the structures, those urinary structures, right? So it can be up here. We've got some sort of kink here. Here there's a stricture, so a narrowed place. This, some sort of scar tissue band, a fibrous band occurred. Stenosis, a narrowed place. What happens if the kidneys are making urine but they can't get it down? It's going to back up into the renal pelvis, and this is hydronephrosis then. And actually this can be even as far down as, down by the urethra or bladder, and can cause this backflow up. And our problem with that is hydronephrosis. So this is a backup above wherever the obstruction is. It dilates and fills up with urine. That dilation and that extra urine increase the pressure. The pressure, when it fills up inside that renal pelvis, it pushes on the nephrons and it does damage. So this can happen one side or both sides, can be, just narrow, or it can be totally occluded. And again, doesn't matter where the structural problem is. The problem is that it backs up into the kidney itself, into the renal pelvis, and then does damage. Vesicoureteral reflux. This is a problem with the vesicoureteral valve. So we've got a valve here that's supposed to let urine go one way, right, from our kidney through the ureter into the bladder. And then when you void, that bladder squeezes down, kind of pushes that closed, and the urine comes out. Well, when there's a reflux problem, it means the urine backflows up into the ureter and kidney, and then after you're done voiding, immediately comes back and sits right here in the bladder, so you don't really get to empty the bladder. A couple of things can cause this. One is overfilling the bladder so that this doesn't close right, and the other is that there's a structural problem with this, and structural problems, they can do surgery and correct it. So I think I just said that. Abnormal retrograde flow. Yeah. So urinary tract infections are very common during childhood. About 8% of girls and 2% of boys will have one. Things that contribute to it. With girls, it's that short urethra. So any germs on the tissue only have, this tiny little bit to go to get right into the bladder. In boys, our rates are higher if they're uncircumcised. The biggest factor is urinary stasis, old urine sitting in the bladder, concentrated urine. So they're a little dehydrated. That urine is being made is concentrated. Holding it and over distending the bladder, having some actual problem with the valve. Constipation, it causes compression on usually on the ureter so that everything backs up. Or then perineal irritation, and this is a bigger problem in girls because the urethra is even shorter. Irritation on the skin harbors bacteria, and there's a very short distance for it to back up and get into the bladder and then move on up.